Good afternoon, everyone, and thank you for joining us for this afternoon's webinar, Aging and Your Brain, Research Updates and Support Strategies, hosted by UCR's Office of Alumni Engagement and Asian Pacific Islander Alumni Board. My name is Peter Hu Tran, and I'm a proud UCR alum, class of 2013. I'm a board member of the Asian Pacific Islander Alumni Network, as well as working as the assistant director of the academic and student engagement at New York University's Tran School of Engineering. So I'm tuning in from the East Coast. I am pleased to serve as your moderator today, alongside with Grace Alba, a fellow API alumni board member. Grace received one of her graduate degrees from CNAS or CNAS and is currently working as a natural history interpreter at the Carnegie Museum of Natural History in Pittsburgh. Grace is a self-described member of the open face sandwich generation, which refers to the generation of individuals currently caring for their aging parents. The subject of aging and dementia and caregiving is of special interest to the Asian Pacific Islander Alumni Network, and we know these are issues that affect us all. We hope today's discussion will give you helpful information and insight. We're honored to be joined today by an esteemed panel of UCR experts, starting with Harmony Chai, a UCR alumna and public health expert specializing in strategy, operations, and systems management. Then Dr. David Franklin, a clinical neuropsychologist at UCR and professor of psychiatry and neuroscience at UCR School of Medicine. And Dr. Xiaoping Hu, Distinguished Professor and Chair of the UCR Department of Bioengineering and Director of the UCR Center for Advanced Neuroimaging. Each speaker will present, then we will move on onto the panel discussion, which Grace will be moderating. For the final portion of the webinar, we will hold an audience Q&A. You can enter your questions in the Q&A box between now and the Q&A portion at the end of the event. As a note, closed caption is available if you click Show Captions in the menu bar. I would now like to introduce our first speaker, Dr. David Franklin. Dr. Franklin is a clinical neuropsychologist at the UCR Health Inland Empire Psychiatry Center and Health Sciences clinical professor in the Department of Psychiatry and Neuroscience at UCR's School of Medicine. Dr. Franklin joined UC Riverside School of Medicine in 2014. He previously worked as an associate clinical professor at UC Irvine School of Medicine and was the director of resident and student wellness there. Dr. Franklin received his Master's of Science in Healthcare Administration from Cal State Long Beach and received his doctorate in clinical psychology with an emphasis of neuropsychology from Alliant International University. He has conducted research in the use of drug therapy for the treatment of stuttering and on concussions and dementia. Dr. Franklin was the assistant director of the UCI Stuttering Center and co-founding director of the UCI Comprehensive Sport Concussion Program, and currently serves as the director of Elder Abuse Forensic Program for the County of Riverside. David, the floor is now yours.
Okay, thank you, everyone. I'm happy to be here and hopefully be able to provide some knowledge regarding the aging brain. So let me go ahead and bring up my slide deck. All right. Okay. So we're going to talk a little bit about the aging brain and talk about some of the neurodegenerative disorders that we see with with our brain and what can and cannot happen. So let's go into the first topic. When we talk about neurodegenerative disorders, usually we're talking between major and mild neurocognitive disorders. Um, we don't use the term dementia as much in the clinical realm as we used to, as we now move toward more a broader version of the domain. So we use the term now major neurocognitive disorder versus mild neurocognitive disorder. When we look at issues with major neurocognitive disorder, we're looking at, especially in regards to Alzheimer's disease, some cognitive deficits that occur at least in two different domains. We can see what was happening before is that we'd only use memory as a dysfunction back in our old DSM-4 books, which require memory dysfunction. That's not true in this day of age, right? Because some disorders now only do not impact memory, but also impact other cognitive domains, such as executive functioning, such as speech, being able to recognize objects, so on and so forth. And for a major neurocognitive disorder to be present, the individual must have some type of impact in their functionality, right? Which is really important. What really separates major neurocognitive disorders versus mild neurocognitive disorders. And in mild neurocognitive disorders, we would see issues in one domain. So, and that domain has to be pretty significantly impaired as compared to normal functioning. And that domain could be memory, could be complex attention, could be executive functioning, could be learning, language, social cognition. And it's for a mild neurocognitive disorder, what was used to be called mild cognitive impairment, that really doesn't impact our functionality per se. And when we mean functionality, such things as paying bills on time, being able to drive, being able to cook, and things of that nature are complex instrumental activities of daily living, remain intact for mild neurocognitive disorder. For major neurocognitive disorders, those areas now become impaired. And a good percentage of individuals who suffer from mild cognitive impairment or mild neurocognitive disorder do progress to major neurocognitive disorders, and some do not. We don't know exactly the reason why. We think genetics may be playing a role in that, but we're getting a better idea of what might be causing some to progress and some not. As I mentioned before, major neurocognitive disorders impact daily functioning, right? And mild neurocognitive disorders do not. And here's a list of some of them. Or they require greater effort to do those types of things, such as driving. Such things may be becoming losses to places they know well, right? Those are some of the impairments that we can see in this domain. Okay. Types of major neurocognitive disorder. So when we look at major neurocognitive disorder, I want you to understand that it's an umbrella. So, or if we use the term dementia, which is an older term that we use, I want you to think of it as an umbrella. And under the umbrella, we have spokes that come out of that umbrella. And there's different type of major neurocognitive disorders. The most prevalent, and the one that we're going to concentrate on today, is Alzheimer's disease. Then there's another type of dementia called vascular, where individuals suffer from cerebral vascular accidents or mini strokes or TIAs. Okay. Other diagnoses are Lewy body disease, right? What Robin Williams passed away from, where we're seeing Parkinsonian type of deficits as well as severe cognitive deficits, which happens with Lewy body disease. Parkinson's disease, individuals who suffer from Parkinson's disease, a good percentage will also develop some type of cognitive impairment due to Parkinson's disease. TBIs, traumatic brain injuries, can also evolve into a major neurocognitive disorder, and frontal temporal lobar degeneration, what's called FTDs, right? We know one famous individual who suffers from this, name is Bruce Willis, suffers from primary progressive aphasia, where they had trouble speaking, right? And these type of disease states actually happen earlier in life as compared to later in life, okay? Alzheimer's disease, right? The most putative risk factor, guess what, is age, okay? The older we get, the more likely you are to develop the disease state. And there are individuals that do not. But above around the age 85 or 90, the 1 out of 2 of us will develop Alzheimer's disease. Okay. However, at that age of onset, we'll probably pass away from something else instead of Alzheimer's disease. So as you can imagine, later in life, we're going to experience these deficits, but something may actually cause death, right? So, and the etiology may be different for that cause of death. Family history. We'll talk a little bit about genetics, which play a role in Alzheimer's disease. Head traumas. Individuals who've had repeated traumatic brain injuries, right? And now we have this term chronic traumatic encephalopathies that we see with individuals who are playing sports, like football players, so on and so forth. They can develop a major neurocognitive disorder. And those that have had TBIs in the past or traumatic brain injuries are more likely to develop Alzheimer's disease. Family family history of Down syndrome is actually a possible risk factor as well too, and possible late onset depression. So individuals who suffer from later onset depression and didn't suffer from that mood disorder before have a greater risk factor of developing some type of cognitive impairment. It's usually after the age of 65, and it is slow and progressive. More common in women than men, approximately 2 to 1. And cognitive impairment noticed first, and then we might see behavioral changes, so on and so forth. Okay. Nerve cell loss. So when we look at the hallmarks of Alzheimer's disease, we're really looking at what's called plaques and tangles. And these plaques are amyloid plaques, right? That cover the outside of the neuron and actually kill the neurons in the brain. And what you can see with MRI, and Dr. Who's going to go over this a little bit as well too, is that there are imaging that can sometimes pick up and see issues with cognitive impairment, right? So on MRI, those who are in the moderate to severe stage of the illness, the MRI may notice global atrophy, meaning that the ventricles in the brain are starting to widen, which means that we're seeing some neuronal loss, right? And when we see that, that could be due to amyloid plaques. And then we could also see tangles, which are very high lipid protein tangles that actually wrap around the neurons and block the transmission of one neuron to the next. Okay. And we believe that these are some of the major components into how individuals develop Alzheimer's disease. Okay. All right. Warning signs. So these are type of things that we want to look at for individuals who may have warning signs to suffer from Alzheimer's disease, recent memory loss affecting job, right, forgetting to do certain tasks or responsibilities, problems with language. What we can see is word finding issues, right? And there's been some really interesting science coming out recently regarding tip of the tongue syndrome, and that actually language may be a precursor to this disease state as well too. So finding words, so on and so forth. However, as we all know, and myself included, being in my 50s, word finding is an issue that actually begins in your 40s and is part of the normal aging process. Okay. But naming of common objects may be an issue as well too. Disorientation in time and place, decrease in judgment, which is really important to understand what the person's judgment and decision making was like back in when the person's in the 20s, 30s, and 40s versus what they're like in their 50s, 60s, and 70s, right? Was the person always a gambler, or to decide all of a sudden to gamble $100,000 on black when he's in 70s and 80s, right? So being able to understand what's normal and not normal, what was pre-existing versus existing is important. Problems with abstract reasoning. So being able to understand how small parts fit into a whole, be able to understand how objects work in conjunction with others is important. Misplacing things, changes in mood behavior. You might see individuals who are become extremely apathetic, right? Or individuals that become impulsive. So you can see a wide range of that, as well as change in personality and loss of initiative. Early clinical signs, such things as asking the same question over and over and over again, right? We see that often in individuals who suffer from the beginning signs of Alzheimer's disease, repeating the same story over and over again, forgetting how to perform common tasks, such as using the cell phone, using the remote to the TV, so on and so forth, keeping track of bills, getting lost in familiar surroundings or places, neglecting to bathe, right? These are all early signs where we have an individual become so apathetic that they don't want to get up and shower and stay in bed, so on and so forth. Or these individuals may just sit what my grandmother used to call the boob tube and just sit in front of the TV for 8 hours, right? And they lose initiation and motivation. The progression of the disease state, like I mentioned, could be slow and can be slow. First, what we can see is some short-term memory loss, some word finding difficulties, trouble with mood, and then we can see, unfortunately, the moderate the disease state where we have more behavioral issues. We can see a little bit more agitation or maybe even aggression, right? Changes in sleep-wake cycle, a little bit of wandering and confusion. We're definitely having trouble with the ADL, so being able to do things like grooming and things like that, we need to be prompted for. And again, wandering is really significant in this population, which is a concern for our community as well too. So really looking after our neighbors is really important. And then, of course, the severe disease state where we start seeing body function start breaking down, right? Incontinence becomes an issue. You see motor disturbances where they have a lot of falls or risk of falls. Issues with now we need more placement, right? And that's going to be important as well, too. Okay. All right. Okay. So how do we diagnose? What are we kind of looking at, and how do we come about making a diagnosis of a major neurocognitive disorder, whether it's Alzheimer's disease, Parkinson's, so on and so forth? History is number one. getting a really good history, what the person was like before and what's happening now. What age did it start? Testing and imaging, with Dr. Who is going to discuss as well too, right? Especially the imaging important, and clinical observations. What are family members noticing as well too? Okay. All right. So, as I mentioned before, my role as a neuropsychologist is we use tests to kind of get an idea where that person's cognitive functioning is compared to other individuals in their age group, right? So we do things like memory tests in multiple formats, verbal functioning, looking at language, attention, executive functioning, looking at problem solving, so on and so forth. A lot of these are done by paper pencil tests, believe it or not, and some of these are also done by computer. Okay. We've gotten more sophisticated in that we can actually even match to individuals of the same education as well as age and cultural background as well too. Okay. So screening assessments can be used, as I mentioned before. Dr. Who's discussed some imaging and then neuropsych testing. These are all important, really discovering what might be causing the disease state, right? Because individuals who are depressed can also suffer from significant cognitive impairments too, and being able to differentiate the two is extremely important. All right, so laboratory tests may include blood tests, chest x-rays, UAs. UAs are extremely important to get what's called a urine analysis to see if the person is suffering from a urinary tract infection, which may be causing the cognitive issues. So really ruling out any infections, really important. Neuroimaging, as I mentioned before, Dr. Who's going to discuss that, but looking at MRIs, are there other reasons that we're seeing the cognitive issues? Is there a mass? Is there a tumor? Are we seeing normal pressure hydrocephalus that might be causing the cognitive issues, right? And then PET imaging may also be beneficial because now PET imaging is be able to use amyloid and understand better how much amyloid's in the brain, right? So as far as treatments go, one of the major treatments that we use and we see it often is called donepezil. It is the common brand names called Aricept. Used to be commercials of a butterfly flying across the screen. And we use what's called the ADAS cog. So it's a cognitive instrument to see how the person's getting better or worse. Mind you, these medicines help to slow down the progression of the memory loss and only use in mild neurocognitive cases, right? So by the time the person's moved into a major, either moderate or severe, these become much more difficult to address. And again, these are kind of, as far as differences, I always tell my patients kind of paradoxical. This is medicine's working if you're not seeing any changes. Okay. So these things are all important. All right. Um, Another medicine called Reminil, galantamine, very similar. They're called acetylcholinesterase inhibitors, something that you get by prescription, and these are all generic. Again, these work very similar. Some are twice a day dosing, one's a once a day dosing. The Aricept is once a day, galantamine is twice a day, and again, used to help slow the progression. These are not cures. Okay. And then what's called another one called Namenda or memantine. And this medication is actually used in moderate to severe individuals who suffer from major neurodegenerative disorders and can be used in combination with Aricept to help slow down the cognitive issues as well as maybe help with some of the behavioral symptoms that might be seeing. Okay. And then some of the novel treatments. Now we've really made some turns within the past year. We started using infusion treatments that are monoclonal antibody treatments that are infused into the bloodstream. And these are doses about once a month for about 6 months and help to remove plaques from the brain. Again, only looking at individuals who have mild neurocognitive disorders. Okay. These are not for individuals who are in the moderate to severe stages, but more in the mild stages. Okay. All right. And with that, I am going to bring Dr. Who in. Okay, and let me go ahead and leave.
Thank you all so much. Definitely thank you, Dr. Franklin, for that enlightening talk. This will be recorded. This is recorded and we'll be sharing the resources after. Our next presenter is Dr. Xiaoping Hu, Distinguished Professor and Chair in UCR's Department of Bioengineering and Director of UCR's Center for Advanced Neuroimaging. Dr. Hu obtained his Ph.D. in medical physics from the University of Chicago. He joined UCR in 2016 and was promoted to Distinguished Professor in 2024. Prior to UCR, he was a professor at the University of Minnesota, Georgia Institute of Technology, and Emory University. He has worked on the development and biomedical application of magnetic resonance imaging, with an emphasis on the brain for almost 4 decades. He has authored and co authored 325 peer reviewed journal articles, and Dr. Hu is currently on the editorial board of Brain Connectivity and is an associate editor of Magnetic Resonance in Medicine. Additionally, he is a fellow of the International Society for Magnetic Resonance in Medicine, American Association for the Advancement of Sciences, and the American Institute of Medical and Biological Engineering. Xiaoping, I will now hand it over to you. Thank you.
Thank you, Peter. So let me start sharing my screen. Thank you all for coming. Let me get started with my screen. Okay, let's see, here we go. So I want to talk about neuroimaging assessment of the aging brain. So, studying of the brain has always been sort of fascinating to me and of course to clinicians. So imaging was used early on to look at the brain, as Dr. Franklin mentioned, so we can look at the brain structure using imaging. Of course, recent developments in positron emission tomography imaging allows us now to look at some markers of brain degeneration, particularly amyloid plaques that David mentioned, and also this tangles, neurofibrillary tangles that's arising from tau protein. Our recent work also look at some additional MR measures, which I will highlight a few at the end of my talk. So these are sort of early studies that was of MRI images of people with, mild atrophy here. This is in the entorhinal cortex, which is, right next to the brainstem here. You can see some atrophy here, more atrophy, and very severe atrophy. And you can see similar structural changes in the hippocampus, which is a structure known to be important for memory. So this is normal subjects. You can see the hippocampus here, and then you can see a reduction of that hippocampal volume. You can see more sort of enlarged ventricles. So these were, these structural imaging studies had been going on for more than 30 years. Now, with the biomarkers of Alzheimer's, there are two things that are important. One is these plaques, amyloid plaques, as shown on the top right here. And also there's this hypophosphorylated tau protein. Once they have this hypophosphorylation, they turn into these tangles as shown on the lower bottom here. Fortunately, there have been a lot of development with PET imaging that you can have PET tracers that can bind to either one of these, so you can image them specifically. So now we can study how AD progresses and how these sort of markers appear in the brain without actually looking at the histology. So these are just some examples of the PET tracers that allows you to look at the plaques on the top and the tau protein tangles in the bottom. Now, interestingly, as David sort of alluded to earlier, is that there has been amyloid pathology has been known for many years, and this is sort of the progression of the amyloid pathology in the development of Alzheimer's. So you start from preclinical AD to mild cognitive impairment and also AD dementia. You can see there's an increased burden of plaques. But these are not necessarily definitive, because there are people with a lot of plaques and not having these AD symptoms. Tau protein is a more recent discovery relative to amyloids, and it's starting mostly in the sort of entorhinal cortex, the hippocampal area. Then it goes to the sort of limbic system and the temporal area, then goes to the rest of the brain. So there is some hypothesis saying that the amyloid appears first, then you have developed this tau deposition, and then, of course, you develop full-blown Alzheimer's disease. Then you have the symptom onset decline. Now, these are actually supported by some imaging studies. Of course, I just want to show you some examples of amyloid in controls and in patients. You can see even some amyloids in the normal controls. As we age, these plaques would develop. But in patients, this is actually mild cognitive impaired patients, that you can see a lot more plaques. Now we can look at the subjects with tau pathology. You can see that with subjects with tau pathology, you have some tau in subjects without amyloid. With amyloid, you can see more tau pathology. You can see this brighter colors here. And of course, when you have full-blown AD, then you can see a lot of tau in the temporal area, and you can see very, very bright colors. So this sort of suggests that, you can look at the tau pathology to actually look at the burden biomarker, so you can combine it with amyloid imaging to look at it. Now, I want to use the rest of my time here to talk about a few sort of emerging MRI measures. One thing that MRI can measure can look at how water molecules move in the brain. Okay, so if you have a tighter tissue, then you have less movement. Basically, if you have a degeneration, then you can have more movement. Sorry, let's go back. So you can see that there is actually a correlation now between tau burden. You can look at the low right bottom here. You can see a correlation between tau burden and also the movement, the water movement. So the higher tau burden, the more water movement, which means there's less integrity of the tissue. Over here, you can see that in the specific areas, it happens in the temporal cortex and temporal lobe, and also in the hippocampus. You can see this the difference between between aged people and the controls. So this is people control. This is with amyloid plus mild cognitive response. You can see this difference. So this is one of our recent discoveries. We can also use MRI, look at another new structure. I mean, not necessarily new structure, but a structure that hasn't been looked at before with imaging. This structure is this needle-like structure on the brainstem. They actually on both sides. I'm only showing you one side. This structure is known as a locus coeruleus. It has not been looked at very often before because it's really small. This is only a couple of millimeters in diameter. So now we can actually see it with MRI, and we see that how the integrity of it is related to brain degeneration. And more interestingly, we can also see how its connection from the locus coeruleus, you can see the right side, locus coeruleus to the thalamus. This is an important connection known as the central tegmental tract. And we can measure the integrity of this. What is interesting that we are still trying to publish these results is that in the patients with a gene that is known to make people more susceptible to AD, this ApoE epsilon 4 gene, in the people who have this gene, you can see the MRI measure on the vertical axis here is correlated with the tau burden that's measured with PET. You can see that there is correlation. Interestingly, such correlation is actually absent in the people negative for the gene. Now, this is a discovery that we recently discovered. We still don't know exactly what it means, but it suggests that if you have a genetic predisposition, then your tau measure may also be easily seen with an MRI measure, as you can see the correlation here. So this is just gives you a little bit an example of what we're doing. I want to quickly summarize what this is another imaging study, I'm sorry. So this is looking at ion deposition. We know that ion deposition is also maybe an indication of neurodegeneration. So on the horizontal axis on the right here is the ion. Forget about what I say here, but this is really meaning ion. And you can see that there is a correlation with ion deposition in the temporal lobe and hippocampus. The tau deposition is correlated with ion deposition. So that means that we can actually potentially, with MRI, to look at this without having to go through very expensive PET study. You know, a PET study usually costs you somewhere around $2,000 to $3,000. MRI would cost you perhaps a few $100s. So I will stop showing more data here, just do a quick summary. So the take-home message is that there have been a lot of advancements in neuroimaging of the aging brain in the last 2 decades. Okay, the neuroimaging now can provide a multiple windows into the brain. This is looking at the brain as we are still living brain, and we can follow it longitudinally. So with regards to neurodegeneration, so these would provide measures more specifically for detection of early degeneration, perhaps, and also for disease progression that monitoring that David mentioned earlier. You can look at it, even look at the treatment, monitoring. However, the caveat is these imaging measures still remain to be fully established for clinical diagnosis and also treatment monitoring, because what I showed you earlier, those differences are not in individual subjects, more in group of subjects. So there's still a lot of research to be done. So I'm showing you some information of what is going on at UCR. You can look at this website. We have an aging initiative at UCR. And also, this is the contact information of the director of the Aging Initiative, collaborator of mine, Lonnie Bennett. So you can also reach out to his contact information if you're interested in volunteering. So I will stop here and bring Peter back.
So thank you, Xiaoping. I am pleased to present our next speaker, a fellow UCR alum. Harmony Chai is a public health professional specializing in strategy, operations, and systems management, working to ensure equitable access, most recently at the Alzheimer's Association and Jepaigo Corporation. She has managed a diverse portfolio of domestic and international health systems, programs across the United States, and also East Africa, South Asia, including Uganda partnering with USAID, Malaria Consortium, and Peace Corps to advance malaria prevention and national health insurance strategies. She holds a bachelor's degree in political science from UCR and a master's of public health degree from Johns Hopkins Bloomberg School of Public Health. So, Harmony, take it away.
Thank you so much, Peter. I'm so excited to be here with you guys today. Give me 1 second as I share my slides. Ooh. Technical difficulties, as we say. Can you guys see my screen? Great. So as you just heard, you saw the what and the why. I'm here for the practical tips and tools to act on it. Let's start with what's in your control. There's a lot more than you might think. Their research shows that there are a lot of lifestyle interventions like regular exercise, eating healthfully, like vegetables, berries, fish, nuts, and hydration.
Hi, Harmony. Sorry. Do you mind resharing your screen?
Oh, I'm so sorry. Did it stop sharing?
Yeah.
Odd. Right here.
All right. We are good now. Um,
I'm so sorry about that. Is that sharing my screen?
Perfect. All right, take it away.
Okay. Can everyone hear me okay too? Great. So some things that you guys, like I was saying, there's lifestyle interventions, regular exercise, eating healthfully, meaning eating healthy, brain activities, socializing and engagement, and then practicing good sleep habits. These are all areas that you can take and do for yourself to manage your own brain health. Since things like high blood pressure and cholesterol also play a role, it's important to keep an eye out on them with regular checkups with a medical professional. And then you can also, even at home, be proactive about regular cognitive check-ins, self-assessments. I have one linked here. The Brain Health Habit Builder, that's um, that was put together by the Alzheimer's Association. So don't worry, these slides, I'm sure we can share them afterwards. You'll be able to link to everything that's I have here on these slides. So understanding early detection, um, as Dr. Franklin had mentioned, there are early signs and symptoms you can watch for, and these are just a very highlight reel of things that you can see in yourself or a loved one. The tip to take away from this is to journal and track memory slips and incidents over time. And then if you're starting to see that there are changes in your memory, it's important to schedule an appointment with your PCP or your primary care physician and mention that you'd like a cognition screening. So during that time, your PCP will you'll talk to them about your symptoms, review your medication, conduct blood tests, and then if they find that there is some evidence that you need to take the short memory tests, like an MMSE or a MoCA, they'll issue that there. The key thing is to make sure that you, when you're scheduling your appointment, that you mention you'd like a cognition screening. But when you see that you have memory problems, sometimes there are a lot of short-term memory problems that are caused by sleep, stress, and mental health or medications that can improve over time. So that's why you need to go to a PCP to be able to identify whether it's short-term or long-term. In the case where during the early detection, experience where it's not just short-term memory concerns, you'll need further screening. And the most important part about this process is making sure that the medical notes clearly document cognition impairment and medical necessity. So medical necessity is the language that needs to be in the notes when you're talking to your PCP. And some of the language that should be included should if you're allowed to look at your medical notes. So some things that they use are suspected AD, evaluation or progress of possible Parkinson's disease, progressive memory decline with abnormal cognitive screening. These are just a limited list of what the language should look like. You can always request your PCP to take a look at your medical notes, and they have to provide specific details about your symptoms, timing. This will help your provider document medical necessity for further testing or detection. So, in the previous slide, I'd mentioned that it's important to journal and track memory slips and incidents over time. That take that with you to your examination. That will be super helpful for their medical notes of determining medical necessity. So I have two podcast recommendations that is just really helpful that I found helpful from NPR, one on prior authorizations. A lot of health insurance uh, coverage require prior authorizations. And then so this kind of breaks that down in a 12-minute episode, as well as another one on navigating claims denied by health insurance. So I have them linked here. So the next step, if there is a medical necessity, the first thing that you should be sent to is to get an MRI, and it's considered a standard initial imaging. So it's like a snapshot of your brain to make sure that there's no physical reasons why you are having memory concerns. And then the next step, if they do see that there's nothing physical like a tumor or brain injuries that are attached to it, and there needs to be further diagnostic. PET scans follow MRI when more detailed brain imaging is needed for that diagnosis. And a PET scan is like Google Maps, where it shows like specificity, like the framework of the brain. Um, a lot of the times, um, Medicare covers PET scans only for specific indications, usually to differentiate Alzheimer's from other dementia with a prior MRI or and neurologist evaluation required. But with prior private insurance, the coverage depends on medical necessity. It the But the coverage may differ based on the diagnostic criteria. So it's important when you know from your physician, your primary care physician or your specialist that you may need an MRI or a PET scan to verify your plan, if your plan will cover the MRI and PET scan and what documentation is required. So this is with both Medicare or private insurance. And then once there is a diagnosis, that's when things kind of feel very, very overwhelming. And so there's studies that show language and cultural barriers are a big reason why people feel dissatisfied with their care or distrust from their doctor. So that is a gap in the system, right? So Guide started in 2024, was specifically designed to help close that gap by giving your family a dedicated person to help with navigating all of it at no cost through Medicare. So there are eligibility criteria, which is linked here. And if you're eligible, here is also a link that helps locate where guide providers are across the country. So guide is there after the diagnosis. But one of the most important things to do is to start those conversations now before you need to. So here are a couple ways you can prepare. And then if you don't know where to start, you can call the Alzheimer's Association helpline, which the number's right here, or you can go to caregiver.org, select your state, and it'll show you what's available to you. And so since caregiving is one of the most loving things you can do for someone, it's also one of the hardest. Asking for help or taking time for yourself can feel selfish, but it's not. It's so taking some of these steps can help lower your stress and make you a better caregiver. More information can be found here at NIH, but you can also go to the Alzheimer's Association or um, uh, the Family Caregiver Alliance for more information. So knowing what's coming is one thing, but actually being on a day-to-day is a different thing. So while you are just starting the journey or you've just been in this for years, these are some of the things that kind of matter the most. So when you're caregiving for someone with ADRD, Alzheimer's disease, and related dementia, it's important to create a safe and familiar environment, access caregiver wellness and resources, maintain a routine and consistency on day-to-day schedules, engage in meaningful traditions and activities, as well as providing simple communication. So the biggest takeaway here is that you don't have to figure this out alone. There are people and programs that can help make this feel less overwhelming. So I'd like to welcome Grace, David, and Xiaoping back onto the screen.
Thank you, Harmony. We've just heard from Harmony Chai and our two other presenters, Dr. David Franklin and Dr. Hu Xiaoping, both on the faculty at UC Riverside. At this point, we will now move on to our panel discussion with all three of our presenters, and then we'll open it up to audience questions. Our first question is, what are the risk factors for developing dementia? Are genetic factors included?
Maybe I should field that one first. Thanks, Grace. And then Dr. Hu and Harmony, you want to chime in. As far as the greatest risk factor, of course, we mentioned age. And I brought it up before, traumatic brain injuries can also be a risk factor. Being female, it's a 2-to-1 difference. So unfortunately, females have a greater propensity of developing the disease state as compared to males. And we don't know exactly the reason for that. I mean, there's some theories regarding hormonal changes during menopause, so on and so forth. But there's as well as genetics may also play a role, and genetics definitely plays a role. And in some individuals, there's a subhort of individuals who have what's called a presenilin gene, where if individuals carry that gene at an early age, there's a close to 100% penetrance of that disease state, but that is extremely rare and actually located in certain areas of the world. So, whereas Dr. Hu mentioned the ApoE gene, if you have so many alleles, you're more protective. You have other alleles, you're less protective, so on and so forth. But those all kind of play a role. Education may also play a role, although I think that's common. That's now probably a little bit different than it was 20 years ago. What we call the cognitive reserve hypothesis: the more you have in your tank, maybe the later the onset the disease process will actually continue. So that may also play a role too. We do know that individuals who have lower educational levels, we're talking less than high school education, are more susceptible of developing a neurodegenerative disorder. Dr. Hu, Harmony, do you want to expand anything more on that?
So, in addition to what Dr. Franklin has said, lifestyle habits, individuals with more education are statistically more likely to engage in healthier lifestyles. So, regular exercise and reduced smoking lowers risk factors for dementia. So, some of these kind of build onto each other. It isn't just genetics, but more so people with increased levels of education also correlates to better job opportunities, higher income, improved access to healthcare, and then reduced exposure to environmental risks. So it's not just one thing in the genetics end of it, but also just the lifestyle interventions that people have um, due to higher educational attainment.
Right. And as Harmony mentions, it's more of a systemic, and we're looking at the person as a whole, right? As Harmony mentioned. So keeping your blood pressure well regulated, keeping your cholesterol well regulated, those all impact the central nervous system. So keeping those down to where they should be is extremely important and helping kind of stave off some of the cognitive disorders that you may see as we get older.
Our next question is, are there ways to slow the progress of cognitive decline? Army, did you want to say again
Sure.
some of the
Like some of if you know the risk factors, then you know the risk factors where we can reduce the risk of increasing those risk factors, right? So slowing cognitive decline is a combination of healthy habits, regular exercise, a brain healthy diet, which can include the MIND diet, which is a Mediterranean based diet. Um, Good sleep hygiene, staying mentally and socially active. Like Dr. Franklin said, managing your medical conditions like high blood pressure, cholesterol, diabetes, is very important because both conditions directly impact your brain health and increase your risks to develop dementia. So there's no cure, but this multi-pronged approach has strong evidence. Research is showing that help delay the progression and help you maintain a healthy quality of life.
Right. In fact, they've actually looked at individuals who have mild neurocognitive disorder and mild cognitive disorder and the progression of the disease state. And they find that people who are more social and interactive and continue to use their brain stave off that progression earlier as compared to those that do not. And what we can see with older adults is that we tend to kind of retreat, right? We tend to stay home and do things like that. We need to do the opposite. We need to be socially interactive because that really fires on all levels of the brain. So that communication, that engagement is incredibly important, as well as just keeping cognitively busy, right? As I mentioned before, the worst thing we can do is just stay inside and kind of isolate. And you can see that in individuals who are suffering from early cognitive decline.
Thank you, panelists. I will now hand it back to Peter Hu Tran for the next segment of our webinar program.
Thank you, Grace. And we will be sending out the recording as well as relevant links shared today. And we want to get to some of the audience questions. And my apologies if we cannot get to everyone's questions. These are really great conversations. And so the first question I have to our panelists from the audience is, I recently attended a seminar at UCR that discussed the effects of wildfire smoke inhalation on respiratory systems. However, we do know that the presence of smoke exposure has a linear relationship with cognitive impairment. How do you expect the data to look like when it comes from the recent wildfire exposure on us as population to impact how quickly we show signs of cognitive aging?
All right, do you want me to hit that or Dr.
Yeah.
Hu, do you want, which one of us want? I'll hit it first, then I'll have you guys expand,
Yeah.
right? I
Go
mean,
ahead,
a lot
David.
of this is kind of wait and see. We will have to see, I'm sure there's going to be some research coming out of that subsection of the individual, up in the Palos Verdes area that was highly impacted, the Eaton fire, so on and so forth. We do know that pollution is, somewhat of a risk factor for individuals on multiple levels, right? So whether it's emphysema or lung diseases, and it can also, we think, impact cognition as well too, right? So these are all things that we're just gonna kind of have to wait and see. We know that wildfires are happening more often. Not now, it doesn't matter what part of the year we're experiencing them. So some of this, we don't really know what the health effects will be like down the line, and whether or not we'll see more issues with cognitive disorders and individuals who are more in the smoke area prone areas. Um, Harmony or Dr. Hu, do you want to expand any further on that?
Go ahead, Harmony.
Well, you know, our environment impacts the way that our quality of life and our health. And so, like Dr. Franklin said, we'll have to wait and see based on that research on how it impacts us. Um, Although we focus on dementia and aging today, you know that our body supports all parts of our overall health. And so air particulates are a factor that can influence the way that conditions show up in our systems.
And thank you so much, Harmony and David, on telling us more about how we can be more diligent when research comes out as it comes, but also our built environment really affects, and we don't know those effects yet. So our last question for today is: can exercise slow the onset of Alzheimer's and other brain diseases? What are the most effective ones? So maybe like a proactive exercise. David?
Right. I mean, we do believe in Harmony. You're going to need to chime in on this. We do believe that exercise is definitely beneficial to the brain, right? That's big. That's no big surprise. One of the things that we do find is that more such things as walking at a pretty significant rate, right? Getting that heart rate up is extremely important for perfusion of blood and oxygen to the brain. So doing things like that are more a proponent of brain health as compared to lifting weights, right? So getting cardiovascularly and what is that, anaerobic, that type of exercise is incredibly important. Things like walking, jogging, things like that to help stimulate the cardiovascular system is incredibly important. We find definitely some effects systematically. And I think what we don't want to do is put the brain as just one area, right? And then some Harmony mentioned before, it's a whole body component that really we're finding that the body is completely interconnected, right? One doesn't separate the other. It's a very holistic system working together. So when you exercise, not only do you get better lung capacity, but then you also get better brain capacity as well too. So exercising as suggested by your clinicians or primary care physicians is incredibly important. And really it is more of the cardiovascularly type of exercise, the walking, the running, the jogging, things like that, getting on a treadmill. That has more benefit than going ahead and just lifting, 150-pound bench press.
And just to chime in, overall, these habits are built at an earlier stage in life. So you could be in college right now, you can be in grad school. in your middle age, whenever. These are all habits that help improve your health and make you or setting you up for success in aging, right? And so, um, lifting weights is good for your bone density. And that bone density will help you with your hip flexors, right? And so all of these elements are really important factors to consider when it's just exercising, and we don't want to make sure we focus on just one type of exercise, because all of our body is connected. These are the lifestyle interventions are really for your whole health, like I've been mentioning. So even though you're exercising, you're running, you're swimming, you're walking regularly, do what works best for you there, and then kind of maintain those lifestyle interventions over time so that once you get to an age where aging is an increased risk factor, you'll be set up for success and have a higher chance of, uh, maintaining the quality of life that you want at whatever age you want. Those are important things to consider.
Yeah, and thank you, Harmony. Dr. Xiaoping, do you have any proactive exercise tips?
Well, I think exercise is definitely important, and we have recently looked at. We actually published a recent paper on grip strength and the brain network, and that's responsible for that. And we see that there's a correlation with sort of the performance of brain area and the grip strength. That's just one example how important exercise would be. That you exercise, you actually also strengthen the brain. That's all I want to say.
Well, thank you so much. And thank you to our panelists, Harmony Chai, Dr. David Franklin, and Dr. Xiaoping Hu. And I want to thank you all as viewers for spending your lunch hour with us. And for those in the East Coast like myself, 3 p.m. If you or a loved one are interested in getting care through UCR Health, you can visit the website for neurology at the link provided in the chat. We will upload this webinar to the UCR YouTube channel next week and encourage you to check out all of the UCR's virtual events and shorts there. You can also see the YouTube link in the chat. I would like to encourage you to follow UCR News on the UCR website for articles about aging, dementia, as well as other research updates. As many of you all know, higher education is facing unprecedented threats to federal funding. This includes the elimination of research grants and deep cuts to the Pell Grant program, which provides need-based financial aid to help low-income undergraduate students afford college. If you would like to advocate and keep funding higher education, we invite you to join Highlander Advocacy Network, which provides regular updates on legislation affecting UCR and provides toolkits for you to make a difference. You can learn more by visiting the link in the chat. Now, all participants will receive a recap email by the end of the week that includes links that were shared today, as well as information about how to get more involved in the UCR Alumni Association through events, alumni networks, and other volunteer opportunities. Thank you all for being with us today, and have a great rest of your day.